Intramuscular injections. Today we'll be covering what we commonly call as an IM injection, otherwise known as an intramuscular. However, we abbreviate IM because it's easier to say, fewer letters, fewer syllables. IM injections are given deep into the central area of a muscle, and we want to select certain muscles that are away from large nerves and blood vessels, and we're going to provide that information for you today, what those locations are. IM medications are absorbed more rapidly than through the sub-Q route, and that's because of the high vasculature that you find inside of muscles. So there's lots of blood vessels that move blood through there, and thereby can move this medication through the system as well pretty quickly. Muscle tissue can hold a larger volume of fluid without discomfort. So as we said before, with sub-Qs, we don't really want to go above 2 ml. And honestly, you probably in most of those, you won't even go above 1 ml. Speaking of the sub-Qs. For IMs, however, the volume can be larger, and sometimes and often is. And of course, any medication that might be irritating to, say, the dermal layer or the sub-Q tissue is best placed in an IM injection. I can think of the injectable birth control, Depo-Provera as being one of those that is an irritant to the skin. So the route is to administer into muscle tissue. We typically use a 2 to 5 ml hypodermic syringe. So the same ones that you'll be using for sub-Q, nothing much is going to change there. The dose is going to go from 0.5, so half an ml, up to as much as 5 ml. We won't be administering that much. However, it is possible to do at IM. However, you should note that doses over 3 ml should be divided and injected separately, which means two separate syringes, 2 separate needles, the whole bit. So you'd put about 2.5 ml in each if it were a 5 ml injection, as an example. That's a rare case. I've only done that once or twice in my career. Most of the IMs that you give will be done in one shot. We use a 22 to a 25 gauge. It says here most often 25 gauge, and that's probably true. But 22 is a little bit larger than you need, although some medication is going to require it. In the case of the birth control or testosterone, when it's used as a hormone replacement therapy, that type of fluid is very viscous and very thick, and sometimes we use as large as an 18 gauge to administer those, which is a pretty good sized needle. But most often around the 25 gauge is appropriate. Needle length, 5/8 for infants, up to 1 1/2 for gluteal injections for adults. And 1 inch is the most common. That's the one we're going to use in the deltoid muscle. And a 2 to 3 inch needle may be necessary for larger patients. I've never had the experience where I've used over a 1 1/2 inch needle. I know that they're available, and if you're doing, if a doctor's doing a spinal injection, they're quite large. But honestly, for our purposes, even for larger people, a 1 1/2 should get the job done. The needle length should be long enough to reach the muscle mass. So unlike sub-Q, we want to go through the sub-Q tissue and into the muscle. And we want to prevent the vaccine from seeping into the subcutaneous tissue. So that means we want to get it well within the muscle mass. However, we don't want to have it so long that we could somehow engage or involve an underlying nerve, blood vessel, or bone. That's very uncommon. As we said before, most of these injections are done in the deltoid. Most are done with a 1 inch needle. And unless your patient is very, very thin, you might go down to a 5/8 or a 1/2 inch. But otherwise, you shouldn't be hitting nerves or blood. Now, blood vessels you'll hit those occasionally. You'll see a little blood come back after you remove the needle, and that tells you probably hit one. Nothing to be alarmed about. It's just going to be a spot of blood. A Band-Aid will fix it. So when we're talking about determining our needle size and length, we want to think about the size of the muscle. We want to think about how thick the adipose tissue around that muscle is. And we want to think about the volume of the material to be administered. And I would also include, once again, how thick is this material that we're injecting. If it's the testosterone I mentioned earlier, we used to call those Jello shots because it was almost like oil. So that's going to be different. You can't administer that with a 25 gauge. You're not going to be able to get it out of the syringe. There's no amount of pressure that'll push it out. So I would also say that has to do with the viscosity of whatever you're trying to administer. Most things that you're going to administer through an IM are going to be very viscous, and they're going to flow right through, and a smaller lumen will be appropriate, but not all. When we do IMs, we want to come in at a 90-degree angle. So you can see here, we're going through the dermis, we're going through the subcutaneous tissue, and we're going into the muscle. So this illustrates very well how we want to approach this injection and what our target is. It's getting inside of that muscle mass. So when we speak of aspiration, we're talking about pulling back on the syringe plunger after the needle is inserted, but before injecting. And we want to ensure that the needle's not in a blood vessel. This is not a practice we really have to follow through with very much. The CDC does not require it for IM or sub-Qs or for insulin or heparin, because in those areas, being the deltoid muscle primarily, and when it comes to insulin and heparin, that's of course the subcutaneous tissue found on the anterior abdomen, there's really no large blood vessels near those sites. So once again, we're talking about for IM specifically the deltoid and the vastus lateralis muscles. Aspiration may be required for larger muscles, and so a ventrogluteal or any injection you do into the gluteal muscle may require that you do aspiration. We're not going to practice it. We'll talk about it a little bit and give you the idea of what it is. I want you to be aware of it. You're not going to be called on to do it often. I did it rarely in my career as an MA. However, when I was instructed, I did aspirate before injecting. So here we are. Some of our common IM injections: vaccines, antibiotics, hormones, fertility drugs, vitamin B12, epinephrine, antiemetics. Those are medications that we use to calm vomiting. Analgesics, anti-inflammatory drugs, cortisone, and contraceptives. Especially in the topic of antiemetics, and doing the IM injection is crucial, because if someone has an upset stomach, if they are vomiting, giving them a pill to swallow, the chances are they're going to vomit that pill back up shortly thereafter. So one way we can ensure that we get the antiemetic into an effective therapeutic space is to inject through an IM route. And some other medications commonly administered IM are antibiotics. Here you see Rocephin. That's a medication I have injected a lot. It usually comes in a powder form. So this is where you'll use the diluent, and you'll put the sterile water at the prescribed amount in with this medication. You roll the medication, the bottle between your hands to mix it. You draw it back up. Something like Rocephin, and those of you, when you get a chance to work with it, you'll find it is very hard to reconstitute. It likes to stay chunky, so it takes a lot of mixing, but not too vigorous, because you don't want to create air bubbles. Bicillin is a long-acting penicillin, and that's another antibiotic that's very commonly given via IM. And typically those two routes are through the gluteus muscle. Hormones are often usually given as glute injections. That's testosterone, I mentioned earlier, estrogen, and fertility drugs. Antiemetics are often given IM through the deltoid muscle, but they can go the gluteal route as well. So we have Zofran, Phenergan, Reglan. Although those are very common, you'll see those in any general practitioner's office, any family practice. And of course, epinephrine is also administered IM. That's one we hope we never have to, but if we do need to, we want to be able to do it quickly, because as we know, that's a life-saving medication. And then, of course, we have the cornucopia of the vaccines that are administered via the IM route. They're all listed here. So I've talked before and mentioned about the difference between Tdap and DTaP, and you can see them sort of spelled out here a little bit. You can also have that form of injection that's just for diphtheria and tetanus, and that does not have the pertussis element. That's that second one you see down, either a DT or a TD. So for some cases, we administer that by order of the doctor, because either the patient doesn't need pertussis, or for some reason they don't want that immunization given. And then the list just goes on. You can read it yourself. These are all, once again, very common. Almost all of these listed here you're going to find in the family practice office as far as administration, as far as stock. Very, very common sets of IM injections that we use. And a few more here. So these are also forms of vaccines. Once again, you can read the list down. You've heard some of these before. You've probably had some of these injections before. In fact, probably most of them, as a matter of fact. And on that note, if you haven't started your Hep B series yet, it's time to get started on that. Your externship will be here before you know it. And the next thing you know, you'll be falling behind and having to get emergency immunizations and things like that. It can happen, and it goes quickly. So if you have not started your Hep B yet, please get that started ASAP. You're going to need it for your externship. Okay, Let's take a look at our IM injection sites. So I've mentioned already a few times the most common is the deltoid. We're going to go over the protocol for that. Vastus lateralis, that's one of the leg muscles in the kind of anterolateral portion of the thigh. And then we have the ventrogluteal, which is a glute injection, but it actually happens from the lateral aspect of the glute, going into a posterior type direction. So we're going to cover all those. The ones we're going to be focusing on in class are going to be the deltoid primarily. We will do a session with vastus lateralis. We will not be doing the ventrogluteal. That injection will be site specific as to how they want you to execute it. We're going to talk about it. You're going to need to know about it. You're going to be tested on it, but you won't actually be performing them as far as I'm aware right now. If that changes, I will certainly let you know. So getting back to that needle length and volume, you need to look at your site and look at the age of the person or the category, the demographic, however you want to put it. And you draw those two lines together and you can figure out. So your site being vastus lateralis, ventrogluteal, deltoid, dorsogluteal. And dorsogluteal is an injection that's not used anymore. It was standard for a long time. It's the one I've done primarily for glutes, but we're not, it's not recommended any further, so we're not going to cover it in this class. We'll talk about it just a little bit later in the lecture. But these are our sites, and then as you can see, according to the age group, what size of needle, what volume we're looking at, and what volume is possible given that site and that age group. So it's a pretty important chart. So look it over well. Be familiar with those, especially, like I said, for the deltoid and the vastus lateralis. Those are going to be the most important ones to us this semester. So there are only 2 routinely recommended IM sites for administration of vaccines. And we'll just say it again. It's the deltoid and the vastus lateralis. Site depends on the age, the degree of the muscle development, and the reason we choose these sites is there are no major nerves or blood vessels near these sites, and when the injection is administered properly, meaning appropriate gauge needle, appropriate length and all of that, there shouldn't be any complications at all, unless of course the unforeseen happens, which in medicine can happen at any time. But by standard practice, 99.99% of the time, using these sites are not going to cause any further complications. You simply deliver the injection, put a Band-Aid on it, and observe your patient before you dismiss them for the day. Okay, that covers our first section. I'm going to pause it here, and then we're going to come back and continue with vaccine injection sites.